Hello everybody and welcome back to this week's ECG of the week. Take a second here to pause the video and remind yourself of this week's clinical vignette. Now let's take a look at her ECG. Alright, so what we're going to do is use the 6-step method that we outlined in our ECG Basics tutorial video. And you can find this on our YouTube page as well as our Facebook page. So the first thing we're going to do is look at the rate. So we'll zoom in here to the bottom. Actually, this is one of the easier overall rhythms to get. However, we're still going to actually go through each of the steps. Many of you guys probably know what this is just by looking at it, but it is still helpful to remind yourself of each of these individual components. So we'll go to the rate first. So we'll find a couple of these nice R waves down here. This one lines up right on the line, and then we'll count the boxes between them. We'll use the 300 method. So 1, 2, 3, and then a little bit more. So we'll say 300 divided by 3 equals 100. With that little bit extra, we'll say it's about 90 beats per minute. So probably 300 divided by 3.2 or something. So 90 beats per minute. That's a good estimate. Next, we'll look at the rhythm. So here we can kind of see that the rhythm is regular. If we move this this distance all the way across between the peaks of the R, they're pretty much the same all the way across. However, when we do get to this second half here, it does become irregular. So regular to irregular. You'll kind of see that there's almost two interpretations for the first half and then for the second half of this ECG strip. Next, we're going to look at the P waves. So we'll zoom in back here to the bottom. We do see a P wave here, P wave here, P wave here, P wave here. So we do see P waves before all of these QRS complexes. So that's good, that's normal. Next, we'll look at the QRS complex itself. Down here, we do see they're pretty normal. They are narrow. We do see notching up here as well as down here. And then eventually it turns into this very wide polymorphic kind of going up and down shape. So again, we'll kind of have two different answers for this, mostly normal and then going to wide and polymorphic. The PR interval, it is present at first. We do have the P waves. So this is about 4 small boxes, which is 160 milliseconds. So this is less than 200 milliseconds. This is a normal PR interval. And then in the second half here, it's unmeasurable. Next is the ST segment. So we'll go down here and we'll look. We don't see any ST depression or elevation here at the J point. We can kind of see that this comes back up to the point here. We do have this sloping, and then we have an inverted T wave. So that's an interesting point there. In the second half, we can't say anything about the ST segment. And then finally, the QT segment. So we don't often look at this in many videos, but for here it is particularly important. So we will take a look. So especially in this section here, we can see from this R to R, it's pretty short. From here, we'll just go from this QRS complex to this QRS complex. It's a bit longer. And then from here to here, it's short again. So this short, long, short interval, the RR interval, is going to be something that we see very often in this type of ECG, which is going to be Torsades de Pointes. So we'll explain that a little bit later. So let's go over our findings. Our rate was about 90 beats per minute. We said it was sinus rhythm, so this is when it's originating from the SA node. We know this because there are P waves, and then it becomes irregular. The P waves are present, the QRS was normal, and then it becomes wide and polymorphic. The PR interval was present at first, and then it's not measurable in this kind of second half. We did have inverted T waves, and then a prolonged QT interval, followed by a premature atrial contraction. So we'll point this out to you down here. So here we can see this, as I said, kind of a long QT. So this is the long section. And then we have, where we would expect to get a T wave, we actually have a P wave and then a QRS complex. So this is a premature atrial contraction, and then this kind of sets off the Torsades de Pointes. And this is our interpretation, Torsades de Pointes. So let's go into a little bit more detail about the QT interval. So this is from the start of the Q wave to the end of the T wave. So this actually encompasses ventricular depolarization as well as repolarization. And it is rate dependent. This is very important. So when measuring the QT interval in a normal QT interval for females, it's less than 450 milliseconds. For males, it's less than 430 milliseconds. And then abnormally would be longer than this. So there's a little bit of gray area here between 450 and 470, but greater than 470, and then greater than 450 milliseconds for males. This is kind of annoying to count out because it's around 10 or 11 boxes. The best way to do this is to actually just look and see if the QT interval is larger than 2 large boxes, and then you want to take a closer look. So many times it's just an easier way to look, and then if it is longer, you can kind of go into the nitty-gritty. So here down at the bottom, we can see the QT interval starts here at this Q wave, the start of the QRS complex, and then here at the end of the T wave. So this is the depolarization, and then the T wave is repolarization of the ventricles. Okay, so here's a quick, just tip. So this only works if the heart rates are below 100 beats per minute. So in a normal, 60 to 100 beats per minute. A normal QT interval, we can kind of just take these R peaks and then cut them right down the middle. And if the T wave occurs before this halfway point, then there's no prolonged QT interval. However, if we do the same thing down here, we split it in half, we can see that this is going right through our T wave. We can say that this is prolonged. Be careful, make sure that you find the rate first. This only works at rates below 100 beats per minute. Again, this is rate dependent, so be very sure to check the rate before using this little tip. So let's talk a little bit about the pathophysiology now. In Torsades de Pointes, it's a type of polymorphic ventricular tachycardia. So this is important. It can degenerate into ventricular fibrillation and sudden cardiac death. It's very important to see this and to monitor the patient and be aware of these changes. The literal translation is a twisting of points. I think this kind of makes sense if you take a look here. The outline here appears almost like a party streamer, as if you twisted a ribbon around the center. So we have this isoelectric line going right through the middle here. And then we have this kind of undulating up and down that we can see. So there are 2 types. There's acquired and inherited. So the congenital Torsades de Pointes is linked to QT syndrome. In this long QT syndrome, there are actually about 17 genes. So there are many different things to look at that can predispose you to having a long QT syndrome. There are also acquired torsades de pointe, and this is often caused by drugs or electrolyte disorders. And any of these that actually lengthen the QT interval, that's kind of the key thing here. If you have a long QT interval, it will predispose you to getting this morphology. So there are a few drugs that can cause torsades de pointe. Some of the most common ones here are clarithromycin, levofloxacin, or haloperidol. You can also get it in patients who are alcoholics if they are malnourished, people who have had really severe diarrhea, as well as low magnesium or potassium. So essentially what a long QT syndrome, if you think about it, is the T wave is moving farther and farther to the right. So the T wave is the ventricular repolarization. So that's really what's happening here is delayed repolarization. And this allows, in the relative refractory period, a PVC or PAC can occur, like we saw in our patient, there was a PAC. But most likely a PVC can occur, and this will result in the phenomenon known as the R on T. So we can get this QRS complex, this ventricular contraction, in the place where the T wave usually would be. So some interpretation tips. The onset is often preceded by this short, long, short RR interval sequence. So I kind of pointed that out on the patient's ECG, but we'll take a look here. If we zoom in, we have this first QRS, the second QRS. So we can kind of see this is a short interval. Next we have from this one to this one, it's a much longer pause, this post-ectopic pause. And then we have from these 2 points, another short interval. So if you see this short, long, short, followed by this polymorphic, kind of just going up and down like that, that is going to be very pathognomonic for torsades de pointe. The RNT phenomenon, which I just explained, so lengthening of the QT, and then you get a contraction in the place of a T wave. And this is during the relative refractory period. That's important to know. This is the twisting of the QRS complexes around the isoelectric line. We said it looks like a ribbon that you twist. And then the polymorphic QRS complexes are preceded by long QT intervals. So we have this, if we go back here to the QT intervals, we're going to be looking for, well, in this case, kind of the cheat, there's 2 large boxes, but we just want to be looking for a long QT interval or something that will dispose a patient to long QT interval. Our patient here had long QT syndrome. They were diagnosed with it. However, if they're taking drugs or other things, they're malnourished, this might predispose them to a long QT interval. So here's an example. We do have a drug-induced ketoconazole and terfenadine. Ketoconazole is an antifungal. Terfenadine is an antihistamine. It's no longer used because it was actually pulled in, I believe, 1998 because of these drug interactions. And we can see kind of here devolving into this polymorphic QRS. And it's getting bigger and then smaller here. You can kind of see the twist, and then it's getting bigger again. Here's an interesting case. So the patient had a history of ventricular fibrillation, stents, and coronary artery disease. He did have an internal defibrillator. However, he came in and the AICD was not functioning. So usually at this point, the defibrillator would kick in and shock the patient back into normal rhythm. The 2 shockable rhythms, as we know, are ventricular fibrillation and ventricular tachycardia, so VTach, VFib. So you would get a shock here and you wouldn't devolve into this torsades de pointe. However, this patient was malfunctioning. So something to think about, just, if the patient does have this, these devices do sometimes fail, so something to look out for. finally, just some takeaways. So we do have these causes. They can be congenital, drug-induced, or acquired. So make sure to check out for all these different scenarios. And then for the management of the patient, we want to give magnesium before taking any bloods from them. You can also try electrical therapy, such as a temporary pacemaker. If they are unstable, they'll need to be defibrillated. And then it's very important to monitor these patients. If they do actually go back into this torsades de pointes, it can devolve into VFib and cardiac death. So it's very important to make sure these patients become stable before giving them the go-ahead. Thanks for watching, and make sure to check out next week's video. Thank you.